let's talk about implant complications, right? That happens in your practice.
Yeah.
What are your steps? I mean, prevention is better than cure.
Yeah. Let's start there.
so-
Let's start at prevention. I think when we see a lot of practitioners, even the setup, let's start there. Setting up our operatory for success so that we can avoid these complications. What steps are you taking in your practice to set up? We're working in a clean, contaminated field. This is not a sterile environment unless we're going into the maxillary space. But how are you approaching a surgery to avoid starting a complication right from the beginning?
So, I mean, first thing comes from the diagnosis. So every problem that we want to solve or patient has a problem has to have a diagnosis. And then from diagnosis, you can only have one diagnosis, but multiple treatment plans.
Yeah.
Then I look at the data that's available.
Sure.
If there is a single implant missing, I'm going to look at what's in the neighborhood. It's kind of like buying a house, right?
Yeah.
You want to have good schools.
Yeah.
You want to have good neighbors, right? Safe environment. So implants are just like you're putting a house, right?
Yeah.
You're not going to put a house in a bad neighborhood. Hopefully not.
I use that house analogy a lot in my practice too. I talk about, hey, if you've got a flood happening in your kitchen, okay, and now you're going to build a new addition in your living room. Well, you're not going to put that extension in your house if you've got a flood or a fire happening in another room.
Correct.
So you're right. I mean, we need to look at that total comprehensive approach. What steps are you taking in your surgery day to ensure success in that case?
So the moment the patient's seated,
Yeah.
patient gets scrubbed in. So we use a chlorhexidine scrub. We scrub all around the face, the mouth.
Inside and outside?
Inside and outside.
Okay.
We're cleaning the skin, remove all the makeup that's there. Because we're working close to the oral cavity, we do not want to put outside bacteria inside the mouth. We want to prevent the cross-contamination. So we use surgical gloves, which are sterile technique as much as possible. And then we make sure that we are not touching the surfaces which are not non-sterile. We want to maintain the sterility. And then the whole goal behind that is we do not want to share our bacteria to the patient's bacteria.
Yeah.
Cross-contamination, I believe, causes a lot of the issues.
Yeah.
When I see the patient still has a makeup on and somebody's trying to do a suture, suture's on the face and it's bringing all the particles from face inside. Highly likely to get contamination in there.
Yeah.
So clean, sterile environment, I believe, is the first key of success.
Do you provide any pre-op antibiotics to treatment?
Most likely, if I'm doing something that's going to cause a lot of bleeding, they would get prophylactic antibiotics.
Yeah.
Depends on what I'm doing.
Yeah.
But if they're healthy, they have a very healthy environment in the mouth, and I'm doing a short procedure that doesn't release a lot of blood, then I'm going to be judicious with my antibiotic.
Yeah. I mean, for my cases, almost all of them, I just give a pre-op dose of antibiotics. Probably double their regular single dose would be for an antibiotic, and then if they don't have anything else that's going on, that's it. They're not getting any post-treatment antibiotics. What about an implant fails in your practice? An implant comes in, they come in 4 months. What are you checking? How are you knowing that there's a failure if the patient's had no symptoms, or if they're having no symptoms? How are you taking out every implant that doesn't look good on an X-ray? Are you deciding? Are there patient parameters that you just have to look at?
So it depends on how the failures is presenting. Obviously, if there's a pus coming out of the site, we know it's contaminated, and at 4 months, I believe it's easier for me to remove that implant rather than trying to decontaminate a already unhealthy environment. So I would remove the implant, clean the environment, let it heal, go back in 6-8 weeks when the soft tissue is healed, either redo the implant if there's enough bone. If not, then we would do grafting on the bone. But I don't like to, if the implant's been in the mouth less than a year and it gets a contamination and it's already failing, I am not trying to salvage that case.
Yeah.
I am just going to remove it, make everything healthy again, and that reduces a lot of morbidity.
Yeah.
If you leave that implant, it's already infected, your chances are it's going to continue causing problems a year after, and you're just losing more bone and more tissue.
Yeah, I think that's key. I think it's looking at the symptoms. Often, if things don't look good on an X-ray, I've got an older patient that has osteoporosis. The Ostel, I take an Ostel and ISQ, instrument stability quotient readings, and they're in the 60s. We're going to go ahead and restore. The patient hasn't had any symptoms. It's an older female patient, 75 to 80, because the challenges of trying to remove that implant and to redo and have a high chance of success. So I think case management is so key in these complications.
I feel like we should try to prevent the complications from happening. A lot of those early failures happens because of contamination.
Yeah.
Or your drills are dull.
Yeah.
And if there's not enough lubrication in the site, and I feel that causes more of a failure scenario.
Yeah.
Other failure scenario that I see in my practice is people have a large tongue and a weaker bone, and if you put the implant and you put a healing abutment, and that tongue is going to play with the healing abutment.
It's a strong muscle.
And it's a strong muscle, and it will keep playing with it until it introduces the micromobility, and ultimately the implant will fail.
Yeah, just to wrap up, I mean, some of these complications can easily be prevented with good pre-op, understanding maybe we should use a cover screw instead of a healing abutment, leave things closed up, let it heal so we don't have those challenges of bacteria entering the sites in a closed environment. So those are some of the basic complications that we sometimes face in our practices. We talk about big complications on those stages, but I think having a little bit of understanding, just the basics, sterilization, what we'd expect in the first 3 to 4 months of healing, and how to handle it. Not every patient and every scenario is going to be treated the same way.
Yep.
You have to look at the whole scenario. So thanks again.
Thank you.
Yeah. Okay.